Yeah, Kelly, you didn't ask me about my pet choice, right? So, yeah, there's some very interesting choices over there. And I would love dogs if my daughter wasn't allergic to it. But outside the dogs, I've always been fascinated by a jaguar and a cheetah. So I don't know how pet friendly they are, but that would be my choice.
Hey, that's pretty cool though.
That's right. So anyway, I am Sunil Sharma, and I'm the professor in chief for pulmonary critical care and sleep medicine here at West Virginia University in Morgantown. And I thought of talking a little bit about interstitial lung disease with a specific focus today on ILD-PH. And one reason I wanted to, uh, hone on this topic was that ILD is so important to our state. We have the highest prevalence of interstitial lung disease than any other state. But also, we have the highest number of women with interstitial lung disease. The prevalence in women for interstitial lung disease is highest in West Virginia, which we haven't really figured out why is the case. So I think these are fascinating facts which we continue to look at. And, interstitial lung disease often goes in as a disease of the lung, which is chronic. But I'll tell you in terms of mortality, its lifespan actually is sometimes less than some of the cancers. So very aggressive disease. And I think we all should be aware how to catch it early. And that's this whole topic about is how do we get to know whom to pick up early and process that. So let's get started with a little case over here. And please feel free to interrupt in between. I would love to have this as a more of an interactive, um, didactic rather than just a one way. This is a real case we saw a couple of years ago, 62-year-old woman with progressive, um, shortness of breath, and she's been a smoker, worsening dyspnea for 6 months, dry, intermittent cough. And every time she gets more shorter breath and has a more worse cough and spell, she's been getting frequent antibiotics and steroids. And over the course of four such events, the benefits have kind of not been as much as she would like it to be. Her initial CBC, chemistry, and normal labs have been within normal limits. Um, so based on this scenario, and if you look at the chest X-ray going back, obviously this doesn't look like a normal chest X-ray. You see a lot of interstitial infiltrates, and they appear to be more predominant towards the bases in the lower extremity with some sparing of the upper lobe. So that's the context which we're looking at. And the question comes up is, based on the scenario, what would you do next? But one thing is this could be just a acute bronchitis or chronic recurrent bronchitis, and let's just continue with the antibiotics and steroids as we've been doing before. Or I would like to order a CAT scan of the chest with the PFTs, or I would like an MRI of the brain, or consider smoke cessation counseling. I don't think you can go wrong with the D choice anytime. I think anytime you have pulmonary disease and you have an actively smoking person, uh, that's really one of the best recommendations. But apart from that, where is the consensus among all of us here? What do you want to proceed with? Anybody can answer. Hopefully nobody's muted.
In the chat, Gina said a CT.
CT. Fantastic. And I think that there are several points in this regards which we want to consider. Um, one is the fact that patients had recurrent events. None of them seemed to be responding to antibiotic and steroid, and it was a recurrent bad case of recurrent bronchitis. You would have some improvement, and you would think that would benefit the patients. The second thing is the X-ray does not look like a bronchitis picture. There is significant parenchymal involvement. There's significant interstitial pattern on the X-ray, enough to concern that there's something going on more than what meets the eye. So I definitely think this is a patient who very urgently needs to be further evaluated. And of course, we would recommend patient to smoke, do smoke cessation, but any further delay in further diagnostics would only be causing more delay in the care of this patient. So 100% marks to the person who's had a CT scan and a PFT. So here's the CAT scan, and I just included one shot in the interest of time, one cut, and the PFTs are also showing that the FVC is 55%, ratio is 77, significant reduction in total lung capacity to 65% of predicted, and a dramatic reduction in diffusion capacity to 30%. And if you take your attention towards this lower lobe cut off the CAT scan, you see, again, widespread interstitial pattern, some nodularity to that. You can see some bronchiectasis changes already occurring, maybe at areas where maybe some ground glass opacification. So certainly looking like a very interstitial process, favoring ILD, considering its lower lobe. Definitely not consistent, as we said earlier, with the recurrent bronchitis picture. So special notice to the very severe reduction in diffusion capacity, which probably is leading to significant shortness of breath. But wait, we got the diagnosis. We think we did the right thing. We got the interstitial. But here's another report in which say the PA or the pulmonary artery seems to be significantly enlarged. And what do you take out of that? Do you say, you reassure the patient that this is not anything abnormal? We often see PA enlargement. Or would you say, well, I'm very concerned about this enlarged PA, I want to order MRI of the chest? Or would you say you would want to order an echocardiogram? And I think some of the answers from our guests are on the chat, so I need to keep an eye on that.
That's okay. Gina and Catherine both suggested an echocardiogram.
Wonderful. So, this is the kind of audience which I would like to have. Just absolutely on top of that. I think I missed out on the slide. So we'll talk a little bit in the latter slides about the pulmonary artery enlargement, but it basically tells you that for some reason, the pulmonary artery is under tremendous stress. And there are multiple reasons for that that could happen. But the next best thing to get done is to order an echocardiogram and further evaluate other reasoning for pulmonary artery enlargement. So here we're going to be talking about pulmonary hypertension in interstitial lung disease. Why is it important? How do we screen for these patients who have PH-ILD? And then how do we manage the patients once we have diagnosed with them PH-ILD? So pulmonary hypertension itself is a very complex topic. And as most of you know, we classify pulmonary hypertension in 5 major groups. And traditionally, we have been basically focusing on the group 1, which is where all the fancy pulmonary artery vasodilators have been approved by the FDA. Close to a dozen medications are now approved. And for the rest of the groups, other than group 4, where you needed to go in and do a surgical evaluation, we didn't have much choices other than treating the underlying cause. So that has been kind of shifting over the last decade or so. There's increased focus on group 3. There's been a lot of studies. None of them has really shown any promise. And other than looking at patients with severe obstructive sleep apnea and treating that, most of the time we just go ahead and treat the underlying cause, whether it's COPD or other chronic illnesses. Other than the fact that interstitial lung diseases now has taken a lot of attention, and we have started looking into the PH-ILD. So again, as I said, this is an interest which has been going for a long period of time, and there's many, many studies looking at all kinds of PH-ILD, IPF, sarcoidosis, pulmonary Langerhans, histiocytosis, so on and so forth. And you can see the prevalence of this disease ranges anywhere from 20 to 80%. And you may say, hey, that's a wide range. Why can't we figure it out? What's the right prevalence is? Well, the reason why it flings so widely between low and high numbers simply is because of the definition you use for a particular study. For example, are you using mean arterial pressure cutoff of 20? Or are you using a mean PA cutoff of 25? And that can change your prevalence. The other more important thing is, are you using echocardiogram to screen these patients, or are you doing right heart catheterization? If you do right heart catheterization, which is a much more stringent criteria, you'll have lower prevalence, while if you do an echo, you may have a little higher prevalence. But even if we take the most conservative figure of 20%, that's 1/5 of your interstitial lung disease in your practice having pulmonary hypertension. And that's still a very, very big deal in our terms, and I'll tell you why it's such an important reason. This is a large study done in a VA system, and they looked at what pressure inside your pulmonary vessels do you start seeing an increase in the number of deaths. I'll see that, between 10 and 18 and 19, it remains flat if you follow the curve, and then it just suddenly takes off. And, before the study was published, the general consensus was that we're going to diagnose pulmonary hypertension at mean PA pressure of 25. And you can see if you take that, which is between 20 and 30 over here, and draw a line straight up, you kind of missed up the boat, because that journey has already been started at somewhere around 18 to 20. And that prompted a lot of introspection in this expert panel and physicians. Are we delaying the diagnosis quite a bit? Can we do something about that? And in the more recent NICE classification of pulmonary hypertension, they have revised the criteria and dropped down the mean PA pressure for screening for 20 millimeter of mercury, which is in line with this finding of increased mortality and increased hospital readmission. So very important finding in terms of characterizing this disease. If you look at pH and IPF, a lot of studies on this regard has been done at Walter Reed in Washington, D.C. One of the very interesting points that we have learned about this disease is that if you have pulmonary hypertension in interstitial lung disease, with everything equal, including the severity of ILD, the PH patient would die much more quicker than patient with ILD with no pH. But even more surprising to us was the fact at the level of pH. Intuitively, we had thought that the higher the pulmonary pressure, the more the deaths, or more advanced the ILD, the more the deaths. But what it is showing is that the mean PA pressure in these patients is not very high. So majority of these patients were somewhere between 20 and 30 mean PA pressure, where these patients had the highest frequency of overlap between IPF and the mean PA pressure. So the pressures are not very high in IPF, and that is another mistake a physician or a provider taking care of these patients can say, well, it's pretty low. I don't think we need to worry about the pressures. They're not too high. So a good learning lesson from that perspective. Now, if you look at pH and IPF, what does it do? So if you take a patient with interstitial lung disease who has normal mean PA pressure of less than 25 in this study, these people have significant exercise capacity. You can see they can walk a lot more than if you had pH with the same amount of interstitial lung disease. These people also drop significant oxygen at the same level of PFTs and interstitial lung disease if you have pulmonary hypertension. And you can see the mortality almost doubles in patients if you had PH with ILD. So significant changes. So this is kind of a clinical correlation or lesson we learned from that is that if you see interstitial lung disease, the pattern doesn't look that severe, but the patient is out of proportion breath for what you're seeing on the CAT scan. Patient can't walk even to a few feet. Patient is having much more drops in the oxygen in 6 minutes. Then that should be a red flag to consider PH-ILD upfront rather than delay that diagnosis. So PA enlargement, I think earlier the group felt that that is an important aspect, and I think I totally agree with that. But it is not a sine qua non for pulmonary hypertension and interstitial lung disease. There are a lot of other conditions which can enlarge pulmonary artery in ILD, especially the fibrosis of the lungs can dilate the PA. Constant hypoxemia, persistent hypoxemia has been shown to cause pulmonary artery enlargement, even if you didn't have pulmonary hypertension. So per se alone, it doesn't represent pulmonary hypertension, but it is a good marker. Now, why is the pulmonary artery that enlarged? And I think that a screen in echo is a very appropriate first line intervention in these patients. So what does pulmonary artery hypertension do in ILD patient? So we often look at the interstitial lung disease patients' CAT scans, and we are very fascinated with the parenchymal abnormalities. We are fascinated by amount of fibrosis. We're looking at GGOs. We're looking at bronchiectasis. We often forget to look at the mediastinum because we don't think there's much money in there. But mediastinum holds a lot of important information in interstitial lung disease patients. One of them is the enlargement of pulmonary artery. If your pulmonary artery is bigger than the aorta, as you can see in here, the cut from the pulmonary artery is bigger than the adjacent diameter of the aorta, the patient has much higher mortality. So we use this PA to aorta ratio of more than 1 as a prognostic marker. And we look at that this is bad news for the patient, even if he has milder level of interstitial lung disease. If you go up a little bit higher on the curve or the cuts, you can actually see the heart, and you can actually make out the diameter of the right atrium to the left atrium, which also, if it is more than 1, suggests that this patient may have pulmonary hypertension associated with the interstitial lung disease. Same is true for, we are finding increased utility of BNP. If you're working in a rural clinic and you don't have access to immediate echocardiogram, but you suspect with the looking at the CAT scan that your pulmonary artery is enlarged, I want to know if it has anything to do with the heart or pulmonary hypertension. A simple, brain natriuretic or BNP testing is very helpful, because if that's elevated, that suggests that your right atrium is under stress, and that can only happen if your pulmonary pressures may be elevated. Pure interstitial lung disease in the absence of pulmonary hypertension will rarely give elevated BNP levels. Now, the question often asked from us is, the severity of your lung disease should correlate with pulmonary hypertension. More the interstitial lung disease, more it should lead to pulmonary hypertension. And that, unfortunately, has not turned out to be true. So we are seeing pulmonary hypertension in patients who have FVC even more than 70. So if you can look at the mean PA pressure, and here we are defining pulmonary hypertension with mean PA pressure of anything 25 millimeter mercury or above, you see the maximum number of patients are having this pressure with FVC of more than 70. So even milder interstitial lung disease can have pulmonary hypertension, and that can put them at a risk for higher mortality and death. So do not trust your FVC as the main biomarker for pulmonary hypertension. Again, the echocardiogram is very interesting and very important and a very good screening test. But I think what we also learned from interstitial lung disease data is you can't put your entire weight and all the eggs in this basket, because in many ways, times the echo is normal, even with the presence of pulmonary hypertension. And the reason why this happens is because the milder versions of pulmonary hypertension can easily be missed on echo. So echo is good at picking up, PA pressures if they are more than 45 millimeter mercury systolic, or right ventricular systolic pressure more than 45. It's much more. If you go to 50, the sensitivity gets even better. But when you're talking of very mild pulmonary hypertension with right ventricular systolic pressure of 35 to 45, a lot of these echoes will come back erroneously, showing a normal echo rather than pulmonary hypertension. And the gut feeling would be, oh, this PA is enlarged just because of hypoxia, and there is no pulmonary hypertension. So be very, very careful if a normal echo comes and patient is having an incessant amount of dyspnea, out of proportion drop in diffusion capacity, PA to aortic ratio more than 1, then consider why we shouldn't be proceeding for further evaluation. And that's where it comes to the gold standard for diagnosing pulmonary hypertension and interstitial lung disease remains the right heart catheterization. And I'll show you some evidence or preliminary data from our group at the end of this discussion, which kind of drives this point home that you absolutely need to have a very low threshold for getting the gold standard testing in these patients. So as I was alluding, that because of this VA data showing that mortality starts going up, even with you have mean PA pressure very low, the Sixth World Symposium, which is a collection of experts in pulmonary hypertension, revised the definition. And now group 1 pulmonary hypertension is defined with a mean PA pressure of 20 or above instead of 25. And the pulmonary vascular resistance definition has also been revised from 3 Wood units to 2 Wood units. And it's basically so that we are not missing these borderline low pH, low pressure pH patients. Again, another important point to do a right heart catheterization is prognostication. So yes, it's very helpful in diagnosing these patients, is very helpful in picking up those borderline pulmonary hypertension patients, but it can also cause or help us with the prognostication by measuring the PVR. As you know, PVR is very difficult to measure from the echo, and a PVR of more than 6 has been shown to have significant mortality in this patient population. So again, you may ask me that, okay, that's a lot of dense stuff we talked about, but even if you have PH-ILD, you just told us there's not many medications for group 3. What are we even going to do about it? Well, this is ongoing investigations which have been going on, as you can see, from multiple years. And believe it or not, many medications have been studied in the field of IPF and pulmonary hypertension, endothelial receptor antagonists, PD5 inhibitors, and even rioxyguad, and each and every medication has failed. Okay, so the investigations into the therapeutic intervention of PH-ILD is nothing but a graveyard of dead and failed studies. So you may say, then what do we have? Well, except for this recent study, which was published in New England Journal, where the investigators, Steve Nathan and his group from, again, Walter Reed, no, I'm sorry, this was the ANOVA hospital in Washington, D.C., they tried a very different way of looking at PH-ILD. And their hypothesis was that this is a lung problem. Maybe systemic medications are causing significant VQ mismatch and causing more damage than help. What if we can deliver these pulmonary vasodilators, especially the strong ones, through an inhaled mechanism? So we do have a drug in the pulmonary hypertension armamentarium called the Tyvaso, or inhaled treprostinil, which has been pre-existing, so it's not a new discovery, but has never been used with the context of interstitial lung disease. So that was a very unique thought process, that maybe we can deliver these prostacyclins straight to the lungs and see if that would benefit these patients better. And this study called the INCREASE study basically looked at it in a randomized controlled patients with, randomly patients get inhaled treprostinil and a placebo group, which looked over almost 16 weeks, so 4-month study. Both the group between placebo and the inhaled treprostinil had very similar characteristics and the etiology of PH-ILD. Majority of them were interstitial lung disease. And what they found at the end of 4 months, that for the first time in this area, they found a significant increase in exercise capacity in terms of 6-minute walk test, while in the placebo group, there was actually deterioration in the exercise capacity over the next 4 months period of time. So this was the first time that a medication with a different route, especially a prostacyclin, has shown improvement in an outcome, a clinically relevant outcome in patients with interstitial lung disease. And who are the patients who benefited the most? These are the patients who had PVR of more than 4 Wood units. So again, reiterating the importance of having a right heart cath in that. These are the patients who had the worst shortness of breath in 6-minute walk test. And specifically, if your diffusion capacity was less than 40%. So again, as we talked earlier, it's very important when you're looking at a PFT of an interstitial lung disease patient and saying, well, the TLC isn't that bad. The interstitial lung disease doesn't appear to be bad, but why is the diffusion capacity so out of proportionately low? And that's not only a good sign or a clue that this patient may need to be worked up for PH-ILD, but also a sign that their response to inhaled treprostinil treatment may actually be very robust. So keeping that in mind, time is of essence in these patients. And again, this is a secondary outcome from the study where they looked at what happens to proBNP in these patients who've been receiving inhaled Tyvaso. And as you know, proBNP is a marker of atrial dilatation and pressure on the right side of the heart. That means the pressure of the right side of the heart was diminishing, because it can see that BNP has steadily continues to diminish in patients who received inhaled treprostinil, as opposed to the placebo group where the BNP continues to be going up in the 4 months period of time. So based on this data, based on the results of this study, FDA felt that there was enough evidence to approved this medication for interstitial lung disease associated pulmonary hypertension, which was done in 2021, and it is now available for real-time use in our patients. Again, we are still looking into who the right patients for that are without going into too much of detail. The patient population which didn't benefit the most was the combined pulmonary fibrosis and emphysema. And unfortunately, West Virginia, we have a lot of this CPFE because our patients are both smoking and sometimes have both interstitial lung disease and COPD at the same time. So got to be very careful in that segment of patients. And, as we looked at other medications, which was a systemic medication, Rioxiguat, which was used in IPF, it actually had to be terminated prematurely because they had increased mortality in these patients. So two things we learned is that systemic medications probably not prime time ready for patients with PH and ILD. The second, if you dissected this study furthermore, a lot more patients had CPFE or combined pulmonary fibrosis and emphysema than other studies. So we are thinking that these patients may not benefit from that. And this is basically showing when they dissected the study further and did a deep dive, a lot of these patients who died had CPFE. So something to keep in mind in these patients. Interstitial lung disease, as I said, is very high. PH also is very high prevalence in Appalachia. And we need to be cognizant that our patient population could be benefited, but also be very careful that this may not be as effective in this population. This is our study published a few years ago, where we showed that 45% of our patients with interstitial lung disease had combined pulmonary fibrosis and emphysema. So again, something to be very careful and watchful for, that we are not employing these medications in the wrong population, the wrong cohort. So this is our program, which is specifically designed for picking up these patients. So we, reach out to folks who are taking care of interstitial lung disease, specifically our own interstitial lung disease program. And then we try to screen these patients for pulmonary hypertension early than later. And, I'm going to skip this for this next slide. So this is our initial data. What basically we did was we looked at every interstitial lung disease patient which we are currently taking care of, and we found 191 that were within the gamut of WVU interstitial lung disease program. We looked very carefully at that, and we had to exclude 69 patients that were falsely labeled as interstitial lung disease. So we were left with basically, no, I'm sorry, there were 135 patients we had to exclude, in which there was no ILD in 69, or they were screened negative for pulmonary hypertension. So we were left with 56 patients who had screen positive ILD and PH combined. How did we do that? Again, looking at the PA to aortic ratio, looking at the DLCO. So this is called the Adelphi criteria, where we look at 3 or 4 indices, and we make a call that this is much more high likelihood of getting PH-ILD. So once we looked at all of these patients in a multidisciplinary discussion, 30 of those patients were invited to get a right heart cath to see and further explore whether this patient truly had pulmonary hypertension. And to our surprise, out of the 30 right heart catheterizations, which were done, again, a gold standard test, 24 of them, very high number, you're talking about good 75 to 80%, actually had PH-ILD precapillary. Only 2 patients did not have pulmonary hypertension, and 4 patients had post-capillary or left-sided heart disease where we cannot use these medication. So 24 patients qualified for this advanced inhaled Tyvaso for these patients category and were initiated on that. So it kind of gives you a sense the burden of this disease in our West Virginia population, even after careful elimination of large portion of patients, and how useful the right heart catheterization is in documenting this disease, which could have easily been missed if we had just done an echocardiogram in these patients. So having said that, I think I will leave some time for Q&A. So my take-home message in this is that we need to look at many things. The new biomarkers for pulmonary hypertension cannot over-rely on echo if it is normal, but PA to aortic ratio is something which I would recommend everybody looking at a CT scan from these patients with interstitial lung disease should focus on. Possibly a good thing to throw in a BNP as a general workup for interstitial lung disease. And if you're surprised by an elevated BNP, you may have hit a gold mine by having early diagnosis of PH-ILD. And then be very careful in patients who have DLCO less than 40% on PFTs, even if it shows mild ILD, because these have a very high prevalence of PH-ILD and may need to have early intervention. And again, I think the first thing we still do is a echocardiogram because it's a non-invasive test and it still gives us a lot of information. But a negative echo should not dissuade you from going ahead and getting a right heart cath in these patients if patient symptoms are out of proportion to the disease that you see on the imaging as well as on the PFT. So we are probably the highest cohort of PH-ILD in this entire state in West Virginia. And we are happy to review a lot of these patients over the phone, over the telemedicine, so they don't have to drive all this way. And we will probably get patients who absolutely need a right heart cath intervention and further treatment. And I wanted to share the referral information just in case it's helpful or you have patient population which you may be thinking the back of your head may benefit from this further evaluation. So with that, I will thank you for your attention and open to any questions which you might have.